Good afternoon, everybody, and welcome to our Share and Learn for Nottingham City ICP. I'm delighted this afternoon. We've got a presentation from our colleagues in Nottingham University Hospitals. My name's Tracy Tyrrell. I'm Deputy Clinical Lead for Nottingham City ICP, and I'm also the Director of Nursing and AHPs for Nottingham City Care. So I'm joined by Hugh Porter, who is our lead for Nottingham City ICP. And what we're going to do is hear a presentation from colleagues Dr. Keith Girling, who's the Medical Director, and Sarah Moppet, who is the Interim Chief Nurse at NUH. We're going to follow the usual format, so please do post any questions, and then we're going to hear a presentation for about 20 minutes, and then we'll take 10 minutes of questions. So a really warm welcome, and we're looking forward now to hearing from both Sarah and Keith. So I'll hand over to them.
That's great, thank you, Tracy. It's very nice to be here. My name's Sarah, and I will start off, and then I'm going to hand over to Keith to take you through the rest of the presentation. So I'll just take my mask off. So just a bit of an overview to start with of what we'll cover today. We're going to do a little bit of an introduction, some of the demographics of NUH, some of the population that we serve. Then we're going to take you through some of the recent challenges that we've had as an organisation, talk to you a little bit about life during the pandemic and some of the journey that we've been going on in our maternity departments. It's a really good opportunity to talk a little bit about our population focus and how that's influencing our strategy at NUH. And then briefly, we'd like to describe some of the opportunities that the landscape in healthcare is really opening up for us as an organisation. So it depends a little bit how you measure it, but NUH is one of the largest trusts in England. We're spread across 3 sites. So we've got the City Hospital campus, the QMC campus, but also we've got the Rote Walk campus, which focuses on audiology, breast screening, diabetic eye clinic and auditory implant programme. So we're very much a 3-site hospital. Both of our main QMC and city campuses take elective and emergency patients. There's quite a lot of emergency front doors at both campuses. So for example, the City Hospital campus receives all emergency respiratory patients and oncology patients. And at QMC, we've got our ED department, which I think is probably the biggest single site ED in the country. We see around 200,000 patients in our ED every year. But we've also got some other emergency front doors at the QMC campus. So we receive direct neuro and surgical patients into our surgical admissions lounges, and sorry, forgot what I was going to say. So an awful lot of activity takes place across NUH. To do that, we clearly need a lot of staff. So there's around 17,000 staff that work at the organisation. There's a huge budget of over £1 billion. There are 87 inpatient wards, around 1,700 beds. We've got about 55 operating theatres, and we see around 100,000 day cases a year, operate on around 60,000 inpatients a year. And we have or conduct over 1 million outpatients attendances in a normal year. This year, during the pandemic, we've seen around 300,000 outpatients virtually using digital infrastructure. So our hospital is organised into 6 divisions spread over our 3 campuses. And as a trust, we are very much a local hospital, providing all the local DGH services. But many of our services also offer a specialised service, so taking the more complex patients. We are the East Midlands lead for major trauma and also neurology and neurosurgery. In terms of teaching and research, we've got a big infrastructure around both of them. We work with Nottingham University, Derby University, and of course Nottingham Trent University. Very large medical school. Any one time we have around 900 medical students on clinical placements and around 420 nursing students. But we also offer lots of other training programs such as physiotherapy. In terms of research, we've got a strategic partnership with Nottingham University, and we're one of the few organisations out of the London-Oxbridge Triangle to have a biomedical research centre and a clinical research facility, with an ambition to expand that in coming years. One of the things that we've been trying to do is align our research themes with the local health needs. So in particular, mental health, respiratory, stroke and liver. We're the fourth most active trust for recruitment to clinical trials. And although that has reduced by about 50% during the pandemic, we've taken part in a lot of COVID research, and we've recruited over 11,000 patients into those really important COVID trials. So this slide just highlights our strategy at NUH. Just a couple of things to point out. Our overall vision is to be outstanding in health outcomes, patient and staff experience, which I think probably says what it is on the tin. But in terms of our promises, our 6 Ps as we call them, you'll notice in the centre there in pink, we describe partners. And in the landscape that we're in now, this is becoming really, really important to us at NUH in defining who we are and how we work. And I think we've seen a lot of examples during the last year, during the pandemic, where in our region partnership working has really strengthened. So these next few slides just really describe where our patients come from. The darker the slide, the greater the activity coming from that area. And you'll see that obviously the city is a really important part of supplying our patients. That's where it's darkest. So inpatients wise, between 20 and 25,000 patients come from Nottingham City. And this slide just really reflects that we take patients from quite a wide area as well as Nottingham City, and about 84–85% of our patients come from our local ICS area. The picture is very similar when it comes to outpatients and also A&E. So you'll see on that slide about 40 to 100,000 patients come from Nottingham City into our A&E department. I'm just going to swap seats and hand over to Keith now.
Thanks, Sarah. So as with every other organisation, we've been struggling with COVID for the last year and the challenges that that's brought to us, and it's required us to reconfigure large parts of our organisation and our pathways through our organisation into COVID areas, non-COVID areas and possible COVID areas. We've redeployed staff from work that they would normally do into COVID areas, and of course we've been very involved in the local testing arrangements for COVID for both our staff and patients, but also more broadly. So the big difference is that everybody on this call will recognise was that in wave 1 our non-COVID services stepped down, and we actually had the most empty beds across NUH that I've ever known for a period of several weeks. And then of course in wave 2 we've kept all services going. So hugely challenging through the last 2 or 3 months, through the prolonged wave that Nottingham saw heading from October up until a couple of weeks ago. So the graphs just show the pattern of what's happened in terms of COVID admissions, and as of today we're under 90 COVID inpatients in the trust, which is not a situation we've seen since the back end of September last year. So very welcome indeed. Yeah, as the slide says, in January we peaked at just fractionally under 500 inpatients. I think we hit 496 as our highest number, which was even in a 1700 bedded hospital. This has a massive impact. And to put that into context, all of our elective work normally runs through 200 of our beds. So this took up all of our ability really to deliver elective surgical care, and we have been constrained to emergency and cancer care for some considerable period of time. So we're now again with everybody else looking at COVID recovery. The graph here just shows what our activity levels have been looking like since June last year in terms of non-electives in red, the electives and day case in the dark blue, and then the outpatients in purple. And you can see that we actually recovered really well from the first surge, and then have maintained a lot of that performance through the last few months. And so running levels that are now above our normal baseline for non-electives, but coming up to around 80% of the rest of our activity. So we're now prioritizing patients. We have a very significant backlog of patients waiting for procedures and operations. So we have some 6,000 patients in the high priority groups that we will be looking to operate on and get through our intervention suites over the next couple of months. And then there's a very long backlog of less urgent cases. Our workforce is, as your workforce, tired and somewhat exhausted at the end of this period. So we're looking at how we support them in this next phase. This just looks a little bit more at the backlogs, and the key graphs at the top here just show what's happened to our referrals. So the blue graph in the middle at the top shows the number of referrals that we were getting per month before the pandemic struck, the significant drop that we saw in April last year, and then a return to around 80% of our baseline. And on the right, the purple graph looks at our 2-week wait cancer patients, and you can see that that's now pretty much returned to pre-COVID levels. But the numbers are really quite eye-watering. So if you look at the overdue outpatient reviews, which is the bottom right-hand graph, you can see that we've got around 20,000 patients still with overdue outpatient appointments, which has come down from a peak of over 30,000 at the end of the first wave last year. So we have continued to clear an awful lot of work despite the recent COVID surges. Sarah mentioned maternity at the beginning, and we were all very disappointed when the CQC visited our maternity services last October and rated our services as inadequate. And we have taken very significant and immediate action through the governance arrangement that's shown in this slide in order to improve that service and to be confident that we're delivering a good, at least a good service to all of our women again. That work is underway. It's now very much in full flow, but it's not going to be a quick turnaround. And so we remain, as I say, completely committed from the specialty ward level through to the board to see the improvement. And of course, we're not the only maternity service in the country at the moment to be under some challenge. And I'm sure people listening to this will be aware of the Ockenden report that came out just a few weeks ago, describing the experience of women and staff at another maternity services and the service and the improvements that were suggested and required to be made in response to that. And so we're making sure that we have one improvement plan that picks up all our own issues, but also picks up the national direction of travel as well. So our ambition is absolutely to get this back to a CQC rating of good within 12 months. As an organisation, we've been really keen to change our thinking to population health and health inequalities requirements. So it's a slightly different way of thinking as an acute trust, but actually thinking about the interventions that we make and what the impact those interventions have on the broader population health. And thinking about the lifestyle risk factors, the diet, smoking, alcohol, physical activity. And the figures in the bullet here around the preventable ill health bed days are really quite staggering. So 50% of all GP appointments, 64% of outpatient appointments, and 70% of hospital bed days are all thought to be preventable ill health. And so this is something that the organisation is now really committed to working on and to supporting primary and community care colleagues with this work. So I chair a prevention steering group across the organisation, which has got really good buy-in and support from both primary care colleagues, but also from public health. And these are just some of the things that we're working on. So we were really pleased at the end of last year to be awarded an active hospitals status by Public Health England, which has provided us with a modest amount of money to be able to develop this within the trust and to support how we encourage activity amongst both patients, but also much more widely to people that have access to any of our services. And we're particularly interested in looking at things like prehabilitation as well as rehabilitation. So the work that has been done internationally around prehabilitation has shown very conclusively how important prehab can be to the outcomes of patients facing major surgery, cancer surgery and such conditions. And so that is something that we're actively taking forward, along with work around smoking and along with work around alcohol. And we know that Nottingham City has higher smoking prevalence rates than the England average. So this is something that's particularly relevant to the Nottingham City ICP, as is the work around alcohol and brief advice that we are giving to patients that use our services, particularly on Friday, Saturday and Sunday nights through the emergency department. So there's much work for us to do, and there's many opportunities for us to work together over the next period as we look at the prehabilitation I've been talking about, the prevention hubs, but also to get a greater understanding of the health inequalities that exist across our system and how we can work together to provide that that much needed care to our Nottingham City population. So I'm going to leave the presentation there and then open this up for questions, if that's okay.
Thank you, Keith. That's great. So we've got some questions coming in, which is brilliant. Okay, so the first one actually probably really leads on nicely from your presentation. So we've got a question around, given your size of the organisation, what's the thinking in the trust about NUH as an anchor organisation? And you've obviously just mentioned it on your slide there.
So NUH is a huge organisation, and we absolutely see ourselves as a significant part of the community of healthcare. but we're not the only part of healthcare. Our patients are your patients. Your patients transition through our organisation and back out again to your care, and we absolutely recognise that we need to be able to work very collaboratively across the system with partners to provide truly patient-centred care. Actually, I would suggest that we talk about patient-centred care, but we only talk about the patient in terms of how it's centred around us, how that person's centred around us, rather than necessarily what's centred around the patient. So thinking about particularly patients with long-term conditions and multimorbidity, how we need to pull that together so that the patients get a very much better service. So we do see ourselves very much as central to that thinking and that work going forward.
Thanks, Keith. We've got another question, probably it may be for Sarah as well, but there's a question in particular around maternity services and your consideration for our BAME population in the city, BAME women and babies. So we're just being asked for what's probably your approach and some of are there particular work that you're doing to meet obviously the needs of our BAME population.
Thanks, Tracy. So really important part of our population. Within maternity specifically, there are actually some specifically focused projects looking at how we communicate better, how we involve the needs and the wishes and the feedback of all of our patients, but actually in particular there are some work streams looking at our BAME population. So it's something that actually during the pandemic as an organisation we've begun to do, I think, some really important work. Obviously we were all very struck very early on in the pandemic by how COVID affected BAME colleagues, and actually I would say one of the really good things that's come out of the pandemic is it really made us evaluate what our offering was, not just for our BAME staff but our BAME patients, and begin to try and understand some of the increasing anxieties that at that time, you know, those particular populations were feeling over and above what we were all feeling. So yeah.
Thank you, Sarah, that's great, thank you. Okay then, so some other questions coming in, just really wanting to understand a little bit more about how you see NUH's role within the City ICP, and it'd probably be great to get Hugh in on this as well as our lead for the ICP, but should we start off with Sarah and Keith first?
So I think it's a really exciting opportunity, having the City ICP as a separate entity in a sense from other parts of the ICS, because the needs are different across the city, and I'm very mindful that there are patients with significant health needs in the city that we are not meeting as effectively as we are in other groups of in other parts of the city, the county, and further beyond, in honesty. So I know, for example, that our provision of cardiac surgery is under-provided to Nottingham City patients compared to patients from every other part of the ICS and beyond. In fact, we provide more cardiac surgery to Lincolnshire than we do to Nottingham City. That doesn't feel right to me, and I've been troubled by it for some time. Because actually there's a health need there that we're not meeting, and working together with the Trust and the ICP working together, I would hope that we can really start to find ways to reach into those communities of need and provide care for them.
Thanks, Keith. And probably good just to get Hugh's view as our lead.
Thanks, Keith. Absolutely. We see NUH as, you know, a critical partner for the ICP. You are a major part of the city and a major part of the health provision, not the only part, but a major part of it. And really, there's two or three bits really. So as Keith has intimated, there's that sort of specific sort of piece of work of thinking around those sort of hospital sort of services and stuff, and some of the pathways, and are they sort of fit for purpose. And it's interesting, I've been starting to do some work on planned care and elective care, and actually, you know, it's sort of, it's, you know, we were splitting it down into sort of long-term conditions, episodic care, but actually then the hard to reach, because actually some people probably don't get to outpatients, and between us we've got to work out, well, you know, if we want to be generally patient-centric, we've got to understand that and live in their world and work out how we go out rather than expect them from that point of view. So I think that absolutely that thought about health qualities, and as Tracy's, you know, I put a little question. It's interesting, you know, the outpatient referrals are back to 80%. Well, where's the other 20% gone? And is that 20% in our most deprived communities, for instance? I don't know yet, but we need to work together to do that. Then the other bit is, again, reflecting on Keith's presentation, the sort of staff resource in NUH is a fantastic resource in that prevention conversation. You know, if you have 1 million people going through outpatients a year, that's 1 million chances to change behaviour. And we all know, all of us in our worlds, whether it's health or it's social care, actually the way to get ourselves eventually to a sustainable position is to sort of co-produce with our citizens a behaviour change across all that we do, and that's blooming hard work. We need everybody pulling in the same direction, and NUH are a key part of that journey as well.
Thank you. So that probably concludes our share and learn. So thank you, Keith and Sarah. Fantastic presentation. It's been really good to have you as part of the City ICP today. So thank you. And we just thank you all for joining us, or if you're watching this through a Twitter feed, we're really grateful for you giving your time to the share and learn. Our next session will be published out, and there's a focus on our healthcare trust colleagues. So we look forward to seeing you at our next share and learn.